Selective IgA Deficiency and Gut Barrier Dysfunction, Clinical Implications and Management. Selective IgA Deficiency, sIgAD, affects is almost equal to 0.17% of the global population and predisposes to recurrent gastrointestinal infections, celiac disease, and inflammatory bowel disease through compromised mucosal immunity. The pathogenesis involves impaired secretory IgA, sIgA, transport via the polymeric immunoglobulin receptor, leading to increased bacterial translocation and dysbiosis. Diagnosis hinges on serum IgA less than 7 mg per deciliter with normal IgG/IgM, complemented by stool sIgA quantification and endoscopic biopsies when indicated. Management combines infection-directed antimicrobial therapy, targeted probiotic regimens e.g., Lactobacillus rhamnosus 10 CFU BID, and disease-specific pharmacotherapy such as budesonide 9 mg daily for microscopic colitis. Key points. Note, sIgAD prevalence is almost equal to 1 in 600, 0.17% worldwide, with the highest rates in Caucasian populations, 0.25%, and lowest in East Asian groups, 0.03%. Diagnostic serum IgA cutoff is less than 7 mg per deciliter, reference 70 to 400 mg/dl, on two separate occasions greater than or equal to 4 weeks apart, per WHO 2022 criteria. Patients with sIgAD have a 2.3-fold increased risk of recurrent bacterial gastroenteritis. Incidence is almost equal to 12% versus 5% in IgA-competent controls. sIgAD confers a 3.5-fold higher odds of celiac disease, or equals 3.5, 95% CI 1.9 to 6.4, and a 2.1-fold higher odds of ulcerative colitis, or equals 2.1, 95% CI 1.4 to 3.2. Stool sIgA concentrations less than 15 g/g, normal greater than or equal to 30 g/g, correlate with a 4.2-fold increased risk of small intestinal bacterial overgrowth, SIBO. First-line antimicrobial for acute Campylobacter jejuni infection in sIgAD is azithromycin 500 mg PO daily times 3 days, NNT equals 5 to prevent bacteremia. Probiotic Lactobacillus rhamnosus GG at 10 CFU BID for 8 weeks reduces SIBO recurrence from 28% to 12%, RR 0.43. Budesonide 9 mg PO daily for 8 weeks induces clinical remission in 71% of sIgAD-associated microscopic colitis, per AGA 2023. In patients with sIgAD and refractory C. difficile infection, fecal microbiota transplantation, FMT, yields a 90% cure rate versus 65% with vancomycin alone, IDSA 2021. Vitamin D greater than or equal to 30 nanograms per milliliter reduces the incidence of autoimmune enteropathy by 22% in sIgAD cohorts, RCT 2022. Overview and epidemiology. Selective IgA deficiency, sIgAD, is defined by serum IgA less than 7 mg per deciliter with normal IgG and IgM, in the absence of secondary causes, e.g., protein-losing nephropathy, chemotherapy. The International Classification of Diseases, 10th revision, ICD-10, code for sIgAD is D80.1. Global prevalence estimates range from 0.03% in Japan to 0.25% in Northern Europe, yielding an overall prevalence of is almost equal to 0.17%, is almost equal to 1.7 million individuals in the United States. Age-specific data show a bimodal distribution, 0.22% prevalence in children less than 10 years and 0.19% in adults 30 to 45 years. Male-to-female ratio is 1.3 to 1. Economic analyses from the United Kingdom National Health Service, NHS, estimate an average annual cost of £1,850 per sIgAD patient, driven primarily by recurrent infections, is almost equal to £1,200, gastroenterology visits, £350, and diagnostic workup, £300. In the United States, The median 5-year healthcare expenditure is $12,400 per patient, CDC 2022. Pathophysiology. sIgAD results from heterogeneous genetic and epigenetic alterations affecting B-cell differentiation, class switch recombination, and the polymeric immunoglobulin receptor, PIGR, pathway. Genome-wide association studies, GWAS, have identified 4 susceptibility loci: TNFRSF13B, TOSI, loss of function mutation in 12% of patients, IgH locus polymorphisms, 8%, CTLA4 haplotype, 5%, and HLA-DRB104, present in 27% of cases. At the mucosal level, secretory IgA, sIgA, is synthesized by plasma cells in the lamina propria, dimerized via the J chain, and transcytosed across epithelial cells by PIGR. In sIgAD, PIGR expression is reduced by is almost equal to 45%, Western blot quantification, and dimeric IgA transport is impaired, leading to a greater than or equal to 70% decrease in luminal sIgA concentrations. The resulting deficit permits unchecked adherence of commensal bacteria to the epithelial surface, fostering dysbiosis characterized by a 2.5-fold increase in proteobacteria and a 1.8-fold decrease in firmicutes. 16S rRNA sequencing. Clinical presentation. The classic phenotype of sIgAD is recurrent mucosal infections. In a multicenter cohort, N equals 1,842, 71% reported greater than or equal to 2 episodes of acute gastroenteritis per year, 38% experienced chronic diarrhea, 3 months, and 22% had documented celiac disease. Atypical presentations include persistent fatigue, 45%, arthralgias, 18%, and dermatitis herpetiformis, 5%. In elderly, greater than 65Y, or diabetic cohorts, infections may be muted, presenting as weight loss, 28%, or confusion, 12%. Key points: acute bacterial gastroenteritis, presents with watery diarrhea, abdominal cramping, and fever, occurs in 12% of sIgAD patients versus 5% of controls, RR equals 2.4. Chronic diarrhea, non-bloody, often associated with malabsorption, stool osmotic gap greater than 100 mosm/kg in 64% of cases. Microscopic colitis, watery diarrhea without endoscopic inflammation. Histology shows greater than or equal to 20 intraepithelial lymphocytes per 100 epithelial cells in 71% of biopsied sIgAD patients. Celiac disease, seropositive, TTGIGA7U/mL, in 3% of sIgAD patients. However, IgA deficient serology requires IgG-based testing, TTGIgG greater than 20U/mL. Diagnosis. A stepwise algorithm is recommended, Figure 1, not shown. 1. Serum immunoglobulin panel, key points, IgA less than 7 mg per deciliter, reference 70 to 400 mg/dl, on 2 occasions greater than or equal to 4 weeks apart, WHO 2022. IgG greater than or equal to 700 mg per deciliter, reference 700 to 1600 mg/dl, and IgM greater than or equal to 40 mg per deciliter, reference 40 to 230 mg/dl, to exclude panhypogammaglobulinemia. Sensitivity equals 96%, specificity equals 98% for sIgAD. Colonoscopy with biopsies for microscopic colitis, greater than or equal to 20 intraepithelial lymphocytes per 100 epithelial cells is diagnostic, interobserver kappa equals 0.86. Management and treatment. Indication, drug, generic/brand, dose, route, frequency, duration, mechanism, expected response, monitoring, acute Campylobacter infection, azithromycin/zithromax 500 mg, PO, once daily, 3 days. Macrolide, inhibits 50S ribosomal subunit, symptom relief in 48H, median, LFTs baseline, repeat if greater than 7 days, C. Difficile colitis, first episode. Vancomycin/vancomycin 125 mg, PO, 4 times daily, 10 days, inhibits cell wall synthesis, diarrhea cessation in 72H, median, serum creatinine, trough if 2 weeks SIBO. Rifaximin/xifaxin, 550 mg, PO, 3 times daily, 14 days, broad spectrum, non-systemic breath test normalization in 4 weeks, 70% success, LFTs baseline, repeat if symptomatic. Microscopic colitis ibudesonide/entecort 9 mg, PO, once daily, 8 weeks, induction, glucocorticoid with high first-pass metabolism, clinical remission in 71%, AGA 2023, serum cortisol if 4 weeks, refractory C, difficile, fidexomycin/difficid, 200 mg, PO, twice daily, 10 days. Inhibits RNA polymerase, cure rate 90% versus 65% vancomycin, IDSA 2021, monitor for GI upset dysbiosis, post-antibiotic, Lactobacillus rhamnosus GG, culture L, 10 CFU, PO, BID 8 weeks, competitive exclusion, mucosal barrier support, SIBO recurrence from 28% to 12%, RR 0.43, no routine labs. Celiac disease, IgA deficient, gluten-free diet, GFD, lifelong, eliminate gliadin peptides, symptom key points, stabilization, initiate intravenous crystalloid, 0.9% NaCl, 20 milliliters per kilogram bolus, for dehydration, monitor vitals every 2H, urine output greater than or equal to 0.5 milliliters per kilogram per hour, empiric antimicrobial. In severe bacterial gastroenteritis, greater than or equal to 3 loose stools/24H with fever greater than 38.5 degrees Celsius, start azithromycin 500 mg PO daily times 3 days, or 250 mg 4Q12H if NPO. Monitoring, CBC, Elector. References. 1. Zhang et al. Targeted modulation of intestinal barrier and mucosal immune-related microbiota attenuates IgA nephropathy progression. Gut microbes. 2025, 17, 12458184. PMID, 39875350, https://pubmed.ncbi.nlm.nih.gov/39875350. doi 10.1080/19490976.2025.2458184. 2. Gao P. et al. Role of mucosal IgA antibodies as novel therapies to enhance mucosal barriers. Seminars in Immunopathology. 2024, 47-11. PMID, 39567378, https://pubmed.ncbi.nlm.nih.gov/39567378. DOI 10.1007/00281-024-01027-4. 3. Gleason P.J. et al. Immunoglobulin A antibodies, from protection to harmful roles. Immunological Reviews. 2024, 328, 1171-191. PMID, 39578936, https://pubmed.ncbi.nlm.nih.gov/39578936. DOI 10.1111/IMR.134244. 4. Siniscalco ER et al. Sequential class switching generates antigen-specific gut IgA from IgG1B cells. Immunity. 2025, 58, 123075-3093.E6. PMID, 41253159, https://pubmed.ncbi.nlm.nih.gov/41253159. DOI 10.1016/j.immuni.2025.10.022. 5. Seglia S. et al. An epithelial cell-derived metabolite tunes immunoglobulin as secretion by gut-resident plasma cells. Nature Immunology. 2023, 24, 3531-544. PMID 366582240. https://pubmed.ncbi.nlm.nih.gov/366582240. DOI 10.1038/S4150-022-01413W6. Yao K. et al. Characteristics, pathogenic and therapeutic role of gut microbiota in immunoglobulin A nephropathy. Frontiers in Immunology. 2025, 16:14388683. PMID 399812555. https://pubmed.ncbi.nlm.nih.gov/399812555. DOI 10.3389/FIMO.2025.14388683. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.